Hi everyone, it's Jonathan. I'm just going to give it a few minutes to allow people to enroll. I see the number kind of ticking up here, so we'll wait till it gets into the 50s or so, and then we'll get started. Hello all. For those that just joined, we're going to give it a few more minutes for folks to get enrolled. I know we just opened up the bridge, so just a sec. All right, well, I think we've got a quorum at least. We'll get started here. Welcome to Region 10 webinar series. I'm Jonathan Wick, Principal of Healthcare Strategy at TransUnion Healthcare. I come from the space. I am was a Chief Revenue Officer at a large acute care hospital in Boulder, and worked in hospitals most of my career. Moved into consulting about 5 years ago. I have a couple books out there as well, and I encourage you to read them if you're interested in what you saw today, just in perspectives of how the patient's becoming a payer. And then this year released a book on helping providers get paid in an era of uncertainty, which is certainly what we're going to talk about today in this WebEx as we proceed. I will dive right into the content. This comes from the IHME website. It's the same data that the White House and the others are using for their projections. Comes out of University of Washington's Institute of Health and Medical Education Department. They are conglomerating sources from the World Health Organization, Centers for Disease Control, American Hospital Association, and Johns Hopkins University, tracking both case rate, social distancing influences, death rate, infection rate, and capacity, and basically putting together a projection that looks something like this. What you're seeing in front of you is New York, which they've predicted the peak fairly accurately as of 2 days ago, yesterday, and you are seeing in the news and others a downslide in terms of the caseload. Deaths are still increasing because there's this lag in presentation of the patient and their advancement of disease as they go. So we're starting to see some daylight. I saw a New York Times article this morning even just get released saying this model is based off of social distancing staying in place. So don't get your hopes up too much in the curves coming down. And you can notice that tail runs into May or so. So we'll see how we're doing. My point is that you'll notice in that purple bar and those numbers in the upper right corner there is a significant shortage of beds in the New York City area, as well as ventilators. And we saw that in the news as they were having the USS Hope more in the harbor there in Manhattan, and also setting up triage tents in Central Park, which we'll go over here in a minute. California, on the other hand, peak is actually going to come sometime around Monday, given back or forth a day or two, and they do not nearly have as high of a peak, and will have a surplus of beds and about 20,000 or so in med-surg regular beds, and they'll probably have about 3 times as many ICU beds as they might need, and they do look like they have a shortage of ventilators that seems to be nationwide. So this is interesting data to go in. They do update it pretty frequently. These graphs have changed pretty remarkably. I've been following it for the past about 2.5, 3 weeks, and they've been the most accurate and comprehensive source of data I've seen. Again, they are a model. Models are models. They're not predicted papers or you know, anything that has a level of accuracy beyond any other model that you would have. But nonetheless, they do provide some insight as far as when peaks are going to happen and at what magnitude, and where there may be resource shortages just based off of capacity. I wanted to share some images because I really do feel this is probably going to be the toughest week our nation's healthcare system and our nation as a whole have seen. It's a picture of a triage nurse triaging patients that have COVID to the blue tent, and those that do not have COVID that are presented to the emergency room for everything else to the white tent. And that really is the reality in a lot of hospitals and hotspots right now in terms of just managing the patient population. Another picture of a nurse triaging or showing the team how to triage on the iPad. You'll notice the fatigues that are worn there in the National Guard, and trying to, they actually are in a tent in Central Park, trying to, you know, explain how the patients are going to come in, what information is going to be captured, what hospital medical records are going to be attached to, those types of things. A somewhat, you know, less sobering or encouraging picture, depending on how you look at it. This is a picture of a billing office in one of the hot spots that is showing how they've staged their equipment for work from home. I know that a lot of you that work in the hospitals have enabled this, if you had not already, just to make sure business continuity and staff safety were made, and allowing for people to, you know, manage their households and maybe their children because they're at home now and their kids are at home. And so that allowed operations to continue, and just a picture of what that looks like. This is a picture from Louisiana. They have converted a convention center there, one of the hot spots, to allow for bed capacity. You could see all the tents and corridors and pipes and things going to handle the surge that's happening there in that convention center. And then finally, this is probably the most dramatic thing that I'm tracking now is the empty beds that are there. And this is primarily in areas of outpatient surgery centers and ambulatory centers and perhaps in the provider facilities that are there, where the CDC and the American College of Surgeons directed hospitals to cancel elective procedures to prevent the spread of the disease, conserve supplies, blood and med-surg supplies, and most importantly, probably beds. I think most hospitals are feeling, that I've talked to, the pinch of this now. These are procedures that are subsidizing the operations and financial liquidity of an organization. They tend to pay a little bit better than the other procedures, and are a large mix of the commercial insurance, which subsidizes most of the other shortfalls in payment from government insurance. And having that happen in combination of this in areas where maybe the surge capacity was not there is something that is certainly drawing a financial strain on hospitals. I've done some numbers too, and I don't think the COVID influx of patients is going to nearly represent the revenue detriment that was created from the deferral of these cases. I've also talked to many hospitals. They've seen a significant decline in just traditional emergency department visits, which puts some weight in the theory that not all emergency department visits are acute, and there were maybe some unnecessary visits there, but patients are actually avoiding facilities as a whole, and EDs are pretty, at least in areas where there's not a hot spot, they're seeing significant downturns in volumes. And so staffing adjustments and expense adjustments and furloughing of employees at some very large systems, I was reading a Becker's article this morning, is pretty prevalent in areas that didn't have a financial position to manage their operations and expenses in a way that they would have liked to. The case rate is higher than anywhere else in the world. When I've presented this deck a few times internally to the folks at TransUnion, and I remember 3 weeks ago when I was comparing our curve to China's and wondering if we were going to surpass that way back when in early March, and here we are 3 weeks later, and the rest of the world, you know, looks like kindergarten compared to what's happened in the United States. That's the bad news. The good news is we are seeing a general flattening of the curve at the top. This data comes from worlddata.org, which is taking information from Johns Hopkins University and the European CDC and kind of conglomerating those and understanding the case rate. And the logarithmic last 3-day average has shown the United States starting to level off to some extent. I also like having various sources, and this comes from the same website, different source. But is showing the U.S. curve up there. We did have a trajectory. If to kind of orient yourself to this graph, the more you are on the right side of the graph, the lower your infection rate, and the more you've bent the curve, and you're starting to see a remission of the transmission of COVID-19. The more you are on the left of this graph, you're seeing your case rate double, every day. We've moved as a country from this 2-day to 3-day transmission curve, and I would argue probably by tomorrow or maybe the weekend, the United States will probably be in a transmission case of once every 4 to 5 days, which is certainly leveling that, and then we'll start seeing some subsiding of case rate and leveling based off of where we're at, similar to probably what's happening in Italy. Would probably be the closest country to compare to in terms of just government structure and capacity and what's happening. This is a snapshot as of this morning surrounding the number of deaths by state and the shelter-in-place orders by state. Most of the country is in a shelter-in-place stay-at-home order. Those ones that are shaded, those ones that are of a lighter color have not instituted said rules, just given their legislature and the case projections and what they're seeing. If you'll notice, they're mostly rural areas for the most part, and they have a fraction of cases surrounding them. If you overlay this with some of that IHME data I showed you, this shows you the states that are currently experiencing their peak. Specifically, in Region 10 here, Colorado, New Mexico, and Utah represent areas that have or are approaching their peak as we speak. Arizona, Wyoming have a few weeks out here to go before they come, and anything here is in yellow is they're impeding. And New York, Washington, Louisiana, and Michigan have been red on this graph. I've been presenting this for some time for the past couple weeks. California and others have kind of lit up as they approach. But this is a good example of showing you that different parts of the country are having different experiences in terms of surges, preparedness, or reactions. I haven't seen anybody coming on the downswing. I think Washington will probably be the first state where we start seeing some rescission in what's happening there, and they will have. I have heard they are sending physicians and supplies across state lines to others as they're starting to see some remission there, as they were, of course, one of the first hot spots in our country. Provider priorities right now in my conversations in just as a consultant, and then just friends here in Colorado and other hospitals that I've spoken to, and both within TransUnion and our teams, we've gathered this information. Most hospitals are in an incident command surge protocol right now. They are continuing to treat the emergent needs of their community. I think that's very important to understand that, providers still, that those of you know this, that you still have patients babies being born and gunshots happening and car wrecks, and this distraction, if you will, of COVID-19 has some business continuity concerns surrounding, separating of that population and making sure that those things are happening, coordinating with city, state, and county officials as far as where the COVID cases are moving, and reporting, educating patients and publics. The hospitals, for lack of a better way, really became traffic cops for lots of communities. Their websites that I've looked at have all had a COVID banner on there saying what you should do, what are the symptoms, here's how you can get a telehealth visit, and also listing the strict visitation policies, basically saying, please don't come here if you feel you have COVID. There's not a lot of things you can do from a treatment standpoint if you're not advanced, but if you do have any of these other symptoms, those are emergencies, and we do need to see you, but let's get you on the horn with a physician remotely so that you're not passing the infection on to others and you're following the shelter-in-place order. I mentioned increasing capacity and supply. This is having, it certainly, I think, has worked in most areas that haven't experienced their peak yet. They've established that. I've seen makeshift field hospitals as well. I'm here in Colorado and in other states, and certainly those that have surged. The revenue impacts are yet to be seen as far as are starting to be experienced, I guess I should say, at many hospitals. I spoke to some this morning even, and they're just trying to figure out how to reallocate staff and insulate, their staffing and their operations and expenses best they can, given that revenue top line has not been realized with this deferral of cases. PPE, obviously, you've all heard about. I won't go over that much. Most states are, and most hospitals nationwide are status quo with billing. They are still submitting claims to carriers. I have seen many suppress the billing cycle to the patient specifically, both on the front and back end of the revenue cycle. So they're not asking for co-pays, co-insurance, deductibles up front, or having self-pay patients kind of figure out how they're going to get paid before they get onboarded. But they are educating, and I would argue from a best practice standpoint, it is good to at least inform, but not collect at this stage. Obviously, it's a very sensitive time. Repurposing staff, reception may be helping with triage, finance teams may be evaluating legislation. I've heard lots of switching back and forth of billing and patient access from a revenue cycle standpoint, where patient access has got the greatest need now because there's more patients coming in, and maybe with rescheduling those cases and those other things, where in 2 to 3 weeks from now, those patient access reps may need to be redeployed to the back to help clean up some of these bills that came in that were fairly dirty, which we'll talk about from a scenario standpoint here in a minute. Priority right now is the patient, community, and staff safety. And then, as I mentioned, the stage of the peak certainly varies by state and community at large and where they're at. I was talking to a friend of mine out on Western Slope, and that their peak may not be until later in the week, simply because they just got a different community out there and different types of a demographic. Anticipated costs will certainly be in the hundreds of billions. I've got models that show it actually quickly approaching trillions, depending on exactly how many patients end up presenting at hospitals and needing those acute care beds, as I mentioned. AHA, AMA, and ANA released a letter March 19th to Congress pleading for legislative relief right now, and they were answered. We'll go over those bills at the end of this session as well. Chad Kirchhoff, the COF-HFMA president, will be providing a webinar up next week to talk through the actual how hospitals can capitalize and understand where those bills funding come. I'm going to walk through now about 8 scenarios that talk through things I think that we're going to see in the various provider arenas surrounding national things that are happening and what the impacts are on the revenue cycle. I have put these 8 things into a brief, these scenarios. I'm happy to provide that brief to you. You can just send me an email at the end and I'll forward that along. We'll also get it to Jessica here at Colorado HFMA and have this deck as well as that brief posted for you there. But I'm happy to send you a copy of it. Just email me here at the end. My information will be displayed here at the end. The first is obviously unemployment. There have been 10 million plus unemployment filings as of the last 2 weeks of March. I've heard projections say that 30% of the U.S. population will be unemployed when this is all said and done. That's the largest it's ever happened in our country's history. It'll be very, very significant. These are unprecedented times. That, of course, impacts income and insurance coverage, and also has a direct impact on how patients will be paying their bills. Payer coverage of bills is variable right now. CMS came out yesterday saying that they will cover treatment as well as testing. The CARES Act and the FFCRA, which I'll go over at the end of this deck, talk about how testing was funded through those bills, but weren't entirely clear on the treatment. You're seeing the commercial payers also adjust their policies. I plan on doing a payer update as well, and I'll let the chapter and others know if we're interested in covering that, just to talk about things they're doing, because they're doing lots of things from a coding, billing, and modifier standpoint and coverage standpoint going forward. So it's important from a recommendation standpoint, the financial assistance policies are adjusted and consistently followed. A snap of yesterday, for example, may not accurately reflect what that patient's financial position is as of tomorrow, and so those need to be reran. Eligibility checks are also important depending on how the eligibility files are given to that clearinghouse and where they sit. If they've got retro provisions, if the person lost their job, they're probably good through the month, but as months change or into next month, those things would change, would come off, and there will be coverage disruption, especially March to April. If you think about when a lot of this has happened in the country, in Colorado, that might be April to May, depending on your admission and discharge status, and they may have had coverage in April, and depending on the confinement rules of the plan, that may continue through May. But if you've had patients scheduled in April and then you're rescheduling them in May and they've lost their job since, that will certainly have implications in terms of the funding mechanisms in place. Adjust payment policies, be very flexible there. It may, either in your own in-house cash team or leveraging a third party to allow for no interest loans or debt forgiveness or extension of payments over time. I'm hearing lots of creative ways of doing that. COBRA and others are things to think about. One of the questions we used to ask on discharge of self-pay patients is, or while they're upstairs, is, did you recently lose your job? Did you elect COBRA? If they didn't elect COBRA, that's you can actually fund their COBRA premiums, and that sometimes is in the best interest if a hospital is looking at funding the payments of a six-figure bill or COBRA payments against a six-figure bill. That's sometimes in the best interest to allow a hospital to do that, and can certainly file on their behalf to do so. And then safety net solutions, ensuring that there's coverage out there that may not be disclosed. An interesting thing here is Medicare has came out and said that they will fund the uninsured treatment costs. Well, if the uninsured are uninsured to you, but you don't know that they had commercial coverage, you're actually losing about 40 to 50% of revenue if you're accepting Medicare payments on those patients versus finding coverage that they maybe had that was not disclosed and they've been discharged and you haven't got a hold of them, but maybe they're dependent on a commercially insured Blue Cross plan, for example. So I could walk through that scenario with you if you need to, but those are opportunities that exist in the recovery phase of this. ED surge obviously is a scenario that's happened in the hot spots. I call these Swiss cheese claims in revenue cycle. They have lots of holes or unclean, if you will. At emergency department, it has a huge potential for claim denials and underpayments and things that happen just because documentation there doesn't, frankly, have the time and consistency that it does with scheduled or elective accounts. And so as those accounts come in, they will have poor demographics and will result in high denial and underpayments and result in significant insurance follow-up. Get creative here is what I've been recommending. Is I've seen hospitals leveraging iPads, tear sheets. I posted something on LinkedIn and Twitter yet last night that talks about some key tips in this area surrounding what you can do. I've been through scenarios where we've had ED surges and large amounts of patients being transitioned from one area to the other. I've talked to other hospitals that have had hurricanes and those types of things happen. And you really need to make sure these accounts, one, are documented. Maybe they have CV-19 on them or something so that you can run a report on them later. And two, you need to have a very quick registration process that maybe is limited in fashion. If you've got 1,000 patients, it's better to get 10 really good things than only get 100 of them with some things, and have some inconsistencies there. And then the third is look at your staffing and really flex them forward and backwards if you anticipate having a surge or need help up front to make sure that that process is hardwired. Outsourcing is an opportunity here as well from a billing standpoint. You may be able to redeploy some of those billers to work on the more complex claims, and maybe $0 claims and others can be looked at. And again, finding that coverage is important if patients are presenting as self-pay or maybe the information wasn't properly provided when they were admitted during the surge. The third capacity surrounds capacity, or third scenario surrounds capacity and supply chain. I've mentioned the deferral of elective cases. Patients were rescheduled into the April and May timeframes, probably closer to May in most cases, given where we've seen the spread kind of come out. But that was to conserve supplies. Obviously, huge impact in lost revenue. Those financial clearance processes will obviously need to be repeated when those patients are brought back. Most authorizations and eligibility checks are only valid. I have heard the payers are starting to lighten the utilization review elements on their plans, especially on the commercial side. But you want to make sure that those things are verified and double checked as you bring patients back in, especially the insurance coverage itself. Those financial clearance processes need to be repeated. Estimates need to be repeated. Staff needs allocation, again, plays here. Hospital margins will be significantly impacted. We're starting to see that. I read a Becker's article this morning showing 90 hospitals are furloughing or laying off employees nationally, and I'm sure that number is much, much larger. Those are just the ones that were in the report. Expense reduction efforts are probably very prevalent at most hospitals right now surrounding staffing, short-term or long-term projects, and any ancillary expenses and growth projects are probably frozen at least until the revenue projections can come back and start seeing some daylight after this. Another recommendation is after this peak happens is do an inventory of your vendors and see where they're at from a revenue cycle standpoint, and if there's some duplicity there, maybe you can save on some expense cost by putting like things together and going with one or two instead of having 5 vendors doing the same thing. From a bad debt scenario 4 here, obviously this is a huge financial impact to the nation as a whole, especially those that are on a fixed income, may have had their portfolios that they use to fund their bills and other things. This scenario from the government talking about treatment costs is great, but that's for people that have a COVID diagnosis. But if you think about the patient who maybe had a hip replacement or a knee surgery or a cath procedure on February 20th, and they've got a bill that they're paying and they just lost their job, that's going to roll into these things, and there's not much financial benefit or relief coming to them from the federal government, other than maybe that paycheck, that check that's going to come in the mail for $1,200 or something, and they will likely probably spend that on something else if a healthcare bill is not ranked very high in the hierarchy of consumer bill payments. And so bad debt is going to be prevalent. Providers have certainly softened their collection efforts for the next 30 to 60 days. Or 30 to 90 days, but it's going to be a bubble, I think, of bad debt as providers continue to explore their options in collecting from patients. I do think best practice is still to inform of obligations and remain to be engaged with patients as they're here, applying flexible payment options, reevaluating your charity. Claim workflow and cash team follow-up should be very, very closely monitored in this. Ensuring financial assistance policies are encompass provisions to address these catastrophic events. I've been on the horn with probably 5 or 6 different hospitals talking through their financial assistance policy and looking at that ceiling in it. It's typically set at a 400 to 500% FPL level. It's not unreasonable to probably have that set at a 600 to 800 to maybe even 1,000% federal poverty level these days, to understand where they're at, and also what types of liquidity they have in their income, given the disruptions that have happened from COVID-19. Financial assistance resources are probably going to be pretty tapped and used and ramped up, I imagine, as these patients come in. Medicare payments, beneficiary bad debt, DISH, and S10 filing should be very, very closely examined. Chad's talk that he's going to give next week, we'll have some more details on that, but there are lots and lots of rules that have changed on the CMS side to talk through, and there's lots of different payments and waivers and things that are in place. There's the Medicare advance payment, and there's DRG increases and COVID modifiers and new codes that need to be submitted to take advantage of the cost share and all of those things, and those payments are going to be very closely evaluated from a claim standpoint. I've also heard the payers are changing their rules pretty frequently now, and so a claim that you submitted yesterday might have paid, and then if you submit it today, it might not, because they're trying to add these modifiers and things to allow them, and that just starts to disrupt the claim payment cycle and the clearinghouse's logic. Scenario 5 surrounds staffing. This may have variable impacts depending on the different facilities within the region. As things from COVID impacted unemployment, illness itself, or just other things caring for one another, I do believe there's going to be a deficit between the claim throughput a hospital had a month ago or 2 months ago versus what they're going to have now. Even if they're completely enabled in a work from home standpoint, there are distractions at home, and productivity may have some impacts there, or they may have just less people working on it because of those competitions for those priorities in terms of staff. Staff are being reallocated to mission critical functions as well, and so they may not have as many billers or registrars or things because they need them to help with triage, and they'll redeploy them as later, or they may have furloughed those folks, and now what used to be a department of 10 is now a department of 3 because of those elective procedures, and that just makes it harder to continue with the claim and intake throughput that's happening at the hospital to help adjust the bottom line to account for that loss in top line revenue. Recommendations here are to create claims capacity. So if you're in a pre-surge scenario, Colorado's, I think, maybe surpassed this today, but other states like Arizona, for example, may not have, and Wyoming and others that may be on the call. Getting your house in order, not that it wasn't in disorder before, but, maybe having overtime and some outsourcing functions happen now to, gain a half an AR day or a couple AR days to create a buffer for you as you experience those claims that I talked about coming through and underpayments and denials and things happening. It would be good to get those prioritized and get as many claims over the wall as possible in the next day or so or a week or so to afford some breathing room for the surge if it happens, and then just the more complexity of the claims that come through and the more labor that it's going to take to get those types of things done. Safety net solutions, of course, make sense here as staff is maybe unfamiliar with the information that's coming in, or there's less staff doing things, there's a higher propensity of error. So it'd be good to validate that the coverage in place is in fact primary and the best reimbursement coverage possible, so that you're maximizing that where you can. Proper financial classes, I think, are very, very important now. I think you're going to see a lot of mismatches with workers' comp, third-party liability, guarantor, the type of payer, whether they met charity determinations and those types of things. So those would be worth revisiting and making sure that that sweep is accurate. And then, as I mentioned earlier, one of those tips, documenting these accounts. It sounds silly, but put it in a field that you could run a report on, so you could just scrub and look at them later. Most of the payers have relaxed their out of timely filing, so if the organization could sustain it, it'd be nice to give them another second look, maybe run a pre-bill eligibility check to make sure eligibility hadn't changed, so you're not wasting anybody's time, and making sure those accounts are fully documented and that you've gotten everything from the patient as possible before they go over the wall. Scenario 6 surrounds hospital financial performance. As you all know, hospitals invest in portfolios as well, and they did not do well in these last few weeks and probably have even more downturn. The rating agencies gave very foreboding results regarding bond ratings in the wake of this first FFCRA ruling that had happened. They have changed the outlook on the not-for-profit sector for hospitals from neutral to negative. It had just bounced out of neutral into positive a few quarters ago, and now it's back, and that's unfortunate, but I see where they're coming from, is that this impact's just going to have detrimental economic effects, and of course that impacts an organization's ability from a capital and operational capital standpoint, their ability to borrow. And so debt expense or income expense starts to become very, very important and prevalent now as your bond rating may be impacted through some of this. So it's important to insulate that cash wherever you can, capitalize on any short-term high-yield revenue projects as soon as you possibly can. Expense reduction efforts are absolutely happening now, and I think we'll continue into Q3, evaluating staffing, education, travel. I know HFMA, at least on our regional level, is looking at converting a lot of our events. We didn't do our not doing our April event. We're trying to do more of these webinars and things, because we realize over the next few weeks it's going to be months, it's going to be very difficult for folks to cut away, and they may not have the ability to send as many folks there. And we're looking closely at our event in the fall and hope things are better by then, but we want to make sure that we're continuing to educate the membership and providing education where we can in the way that's affordable and accessible to the teams. Productivity and staffing models should also be critically realigned. Labor cost is the number one in a hospital, and those things are certainly being looked at. I've talked to several hospitals today, but what are those productivity things? Those have all shifted with these elective cases being deferred. And then there should be absolutely active planning occurring for the intake and allocation of these federal assistance funds, the short-term business loans for organizations that have less than 500 employees, the money coming out of CARES, the Medicare advance payments, and those types of things. And as I mentioned, Chad, I'll be going over that next week, but you should be thinking about that now. And American Hospital Association, for example, sent out something that said a recommendation to hospitals saying that they should request $25,000 now per inpatient bed. And I could forward that along if folks need it. Scenario 7 surrounds the newly insured and non-traditional visits. So FFCRA funding allocated federal dollars, and then they also adjusted the FMAP by about 6.2%, the federal Medicaid adjustment percentage, to help increase dollars for matching for those Medicaid states. Consumers that have never been sick will become patients, and we'll have new demographic information. There are mechanisms for COVID diagnosis to have a state that was not expanded to Medicaid allow a patient to now be in Medicaid, and so they can be enrolled. And as they're enrolled, there may be demographic information that is not accurate and eligibility information that's not accurate, reflecting that patient's coverage as they move forward. Obviously, COBRA, USERRA, Medicaid, and other charity will all have disparate results to patient yield given the fluctuations and disruptions in coverage. Recommendations here, again, are to ensure identity and eligibility checks are performed consistently and hardwired. I can't tell you how many hospitals I've been in and they're like, oh yeah, we run eligibility. You run it, but are you looking at it? And if you're not, and if you're looking at it, are you doing anything different when it comes back? Because you're going to see in the next few weeks eligibility checks that look odd, that don't identify patients, and those patients should absolutely be switched to self-pay, and you should be figuring out and making outbound calls and saying, hey, you know, we ran your insurance, it doesn't look like it's effective anymore, can you give us another card, or what's happening? Because you want to accelerate those charity things or find the other coverage or get that other information as soon as you can, because it's a waste of everybody's time to bill an insurer that doesn't have any coverage for them, and that just kicks a can down the road. Again, adjustment of payment policies and flexible payments, very important as patients' financial position have changed and they're newly insured. They may not be aware of the deductibles and coinsurance that they have. Their payer may be one that doesn't fall under ERISA and maybe following a state rule. It may be a self-funded plan, for example, and those payment options may not be waived in that type of plan. They maybe have a short-term benefit plan that doesn't have the benefits being waived and the coverage being waived for their COVID options, and they're not familiar with how those things get paid. And so it'll be very, very important to meet those patients where they are as payers and figure that out. Intake policies and procedures for financial clearance should be clear. You're going to see new insurance, new patients coming in, and with that comes new errors. Make sure these things are ran at intervals to that ID and eligibility and insurance coverage is applied. And of course, if coverage isn't disclosed in that ED scenario, as I mentioned, it's probably good to run insurance discovery if you're not, to find insurance that was not disclosed or known. That runs about 1% to 5% for most providers, and that's a lot of revenue that'll be left on the table and in self-pay if it's not there, or you'd be accepting Medicare allowable given some of the new rules, and you'd want that commercial insurance to pay instead if you can. The last scenario I'll go over really surrounds chronic disease and illness. I was reading an article this morning that talked about a lap chole patient. It was from the New York Times, a lap chole patient that was scheduled to come in a couple weeks ago, and his appointment was deferred a couple weeks out. Obviously, he wasn't that acute, but as things happen, his progression of his condition may amplify during this time when these elective visits are out there. And as you all know, if you've read my first book and you've talked with me before, 10% of the patients, or 10% of people who access healthcare represent 90% of the cost, and those typically are those ones that have chronic disease, obesity, diabetes, congestive heart failure, COPD, you can name them with me, and a lot of those have well visits that may or may not have been converted to a virtual visit, but they have medications, they have contacts that may have been disrupted through this, and in that, their acuity may accelerate, which means their cost will accelerate as they get into a higher level of acuity, and then you, of course, may have affordability or coverage gaps, which, of course, will present bad debt going forward. Recommendations there are to identify these vulnerable populations and make sure that they have access and primary care and interventions, and they're not lost in the shuffle as you're focusing on the acute surge patients that are coming in. Social determinant risk data and model is very interesting here, and actually could play both in terms of what the patient population that was impacted and then what future populations might be impacted going forward. Financial assistance checks need to be performed periodically as these patients' financial position may have changed because now they're unemployed or because they got unemployed because their condition got worse. And those financial assistance policies, of course, need to have flexibility that arrange for those sorts of cost burdens. I summarized these. I have them in a brief as well that I'm happy to send out. We'll get that posted on the website, but I kind of put them in a bulleted list here. Pre-COVID, this is what I'm seeing kind of as a top 6 or 10 list here of what hospitals and providers are doing. They've suppressed their statement collections if they're early out, in-house, and third-party collections, at least for the next month or so. They've accelerated their cash wherever they can. They've put resources on getting their claims inventory as clean as it possibly could be pre-surge. Standardizing work, really enabling work from home, establishing a streamlined process for Medicaid enrollments. As you start seeing that happen, I don't know if you've heard, Congress has a 4th package that's coming out, and one of the elements in there is talking about ACA and exchange, and we'll see how far along that gets across the aisle as it comes. But, Medicaid enrollment, at least for the COVID patients, was something that came out of FFCRA from a testing standpoint, and there's some provisions in CARES as well that have some elements there that are impacting Medicaid eligibility enrollment as well, and also will impact payment. Infrastructure and training, that's obvious, that's been happening. Do we have enough staff? What staff can we not need? Do we not need, given that we've always needed them, but what staff can we afford to not leverage right now, given the deduction in elective cases? And are there ways, I've heard of creative ways, hospitals are maybe, extending the vacation bank or illness bank to them, but not having them work on site, and then hopefully after a month or so bringing them back. Others are just laying off, some are furloughed, and some are just continuing as usual and trying to manage other expenses where they can. Short-term revenue cycle management lift projects are also in place. Certainly have seen a large-scale deprioritization of projects, contracts, anything that's happening with vendors, and any kind of growth or construction that's happening in a hospital has been put on hold. And then the Medicare advanced payment planning is certainly starting to happen now. What do these dollars mean? How do I get them? How do I apply? How much should I ask for? When do I have to give it back? What's my CMI going to look like after all of this? Is my case mix index going to actually go up or down? Is that going to impact my finances? How's the DRG payments going to be impacted? I'm getting a 20% increase on these COVID cases. That type of thing are all very, very important things to understand before your surge happens versus after. After the peak, I think it's an opportunity to kind of recover, reschedule and re-engage those cases that were deferred. The inventory will have some dirtier or unclean claims in them with some denial propensity. I talked to a hospital this morning that said, we sent something that denied yesterday, but it paid today, and then vice versa. I think the rules are kind of moving around, so I think that's very, very likely there's going to be this bubble in a hose of claims inventory. 3 healthcare laws had impacts for funding and billing. Transfer DRDs, DISH, S10, advanced payments, and others are all going to be impacted by outcomes of those bills as they went through. I'll go over those here at the end. Payment integrity will be very, very important to review and make sure those staff are understanding these coding rules. AMA has released guidance. CMS has released guidance with the new ICD-10, HCPCS, CPT-4, and other codes that are out there, DRGs surrounding the COVID diagnoses, to make sure that cost sharing provision is waived, at least on the Medicare side, and then on the private payer side that have implemented that policy and that benefit plan, depending on who the plan administrator is. Transition of bad debt over to charity where it can. So those FA accounts that maybe weren't performed or were partially performed will need to be brought across the finish line from an eligibility standpoint, especially if the policies were adjusted to be more liberal in terms of scope of patients that they're going to get. And then there will be a huge cost reduction effort, I believe, in late Q2, early Q3 for most hospitals as they try to recover from the financial impacts of lowering their case volume and the severity of the COVID cases that hit their rooms. That was a lot. I'm going to take the last 5-10 minutes here and just give you a brief summary of these bills that got passed in the last few weeks. Again, Chad's going to be going over these next week, so I didn't go too deep on these, but there were 3 bills that rapidly went through the legislature at the national level. The CPRSAA, or the Coronavirus Preparedness Response Supplemental Appropriations Act, $8.3 billion there. Primarily hand grenade, if you will, being thrown at the COVID virus as a whole, mainly surrounding testing, vaccine development, and the research labs. Families First Coronavirus Response Act, the FFCRA, $100 billion two primary areas of funding there were to CMS and employed sick leave. And then finally, the CARES Act, the Coronavirus Aid, Relief, Economic Security Act, largest bill, relief bill passed in the country's history of $2.2 trillion with a T dollars funding for bailout of hospitals, airlines, small business, and of course those checks that several people are waiting for to hit their bank accounts here soon. I'll walk through each one of these just briefly in terms of how the dollars are allocated. $8.3 billion again in the CPRSA Act that came through. $6.7 billion of that was on the domestic side, as I mentioned, primarily in detection therapy and vaccines to really spin up the labs. And try to figure out how we could test and treat and get a vaccine to market as soon as possible, preferably before next fall when flu season picks back up, because there are studies out there that are showing that COVID could rear its ugly head again when the season starts back up, and will continue actually here, depending on which model you're looking at. There hasn't been much of a decline, but we're starting to see, at least in our country, it leveling off. 1.6 billion was sent overseas for similar efforts, but moving on to FFCRA, $100 billion there. CMS funding was 56.3 billion of that. Employee paid sick leave and child leave was 41 billion. Significant impacts to the FMLA rules. Employers have dug in. The HR departments have certainly dug in to look at those. Good benefits there to allow folks to access those dollars and get that leave so that we can keep essential services running in our country, understanding that with schools and sicknesses happening, that there were some safety net provisions happening for the general population as a whole. CARES Act surrounds 2.2 trillion, as I mentioned. Diversified layout here. Those loans to corporate America are there at 500. The Paycheck Protection Program, those checks are there in gray on the left. Unemployed workers, specifically to hospitals, about 1.7 billion was allocated to them. 100 billion for COVID-19 related expenses and lost revenue. I went through the daunting task last week of actually looking through these bills and laws and diving into the paperwork. Very, very complex rules. I'm looking forward to Chad's talk next week. Lots of provisions in there surrounding expanding your facility, construction costs, staffing overtime, all kinds of things. And it's going to be very, I think, troubling and difficult for us to navigate both where those dollars are applied and how to get them. Interesting provisions also, they allow non-expansion states to expand Medicaid to COVID-19 patients. Some other provisions that were outlined in CARES is the funding of treatment and testing on CMS type patients. I'm not exactly sure how that's gonna work on the uninsured side. If you imagine an uninsured patient came in, are they instantly enrolled in Medicaid or Medicare? And then when that claim goes, how should that claim go if they're uninsured, and how will it? And I know it'll get paid at Medicare rates, but it's just a confusing claim cycle for me. So I'm researching that as well. The 2% Medicare sequester was certainly delayed till the end of the year. DRG payments I mentioned increased by 20% for all COVID diagnoses. The DISH payment cuts that were scheduled for next month were delayed until after Thanksgiving in November. That was a $4 billion, and then the schedule will pick it back up again. And then, of course, probably one of the more important provisions in the CARES Act surrounds this Medicare advance payment, which is not new. They just accelerated. It's been there for a while for other kind of national disasters, but it basically allows you to get an advance payment on your Medicare dollars for the next 3 months, and then you could pay that back if you drew too much. Or if you drew too little, you can just submit claims as normal. But Chad will have more information on that as we proceed. I know that was a lot. I know I spoke at like 85 miles an hour, but I wanted to make sure I allowed time at the end for questions. And so Jessica and those folks will, we certainly could put them in chat, or we can unmute lines if we want to do that, or whatever folks want to do. In terms of asking me, or you can get a hold of me. My information is here at the bottom, jwiik@transunion.com as well, but I'm happy to open it up for questions now if there are any.
Chad, in our chat panel, we do have a question from Jeff, and he says, how soon will our hospitals recovery financially from how soon will our hospitals recover financially from this? And will there be any revenue margins in the future we will be able to experience?
Yeah, so I didn't get into detail too much on margins, but most not-for-profits run in the single digits. You know, the better ones are in the higher end and maybe double digits, and then the ones that are maybe in the rural areas and others are on the lower end. Depending on the financial position of the hospital before this happened and the impacts of the deferral of those elective cases, I anticipate a lot of hospitals going into the red for most of Q2. And then I think, depending on how quickly they can get these elective patients back and offset the costs and take advantage of the money from the CARES Act and the FFCRA bill that went through to cover those treatment costs and other things, they should hopefully approach breaking even before the year's out. I do think they're going to see, and I'm just spitballing here, a 3 to 10 point cut in their profit margins depending on how many cases they had, how many cases they deferred, and how financially solvent they were before any of this happened. And so my best case scenario would be you'll start to see hospitals return to normal levels of margin late Q3, early Q4. Worst cases, it's Q1 2021 before things start to look normal, if I'm using air quotes. I hope that answered your question.
Thanks, Jonathan. I am just going to quickly answer another question we've got a couple of. The presentation will be made available to you all. After this is concluded, we will also be providing a link to a
I think Jessica broke up a little bit. I think she was going to say we're going to put a recording on the website so you could see it that way.
That is what I was going to say. Thank you.
You're welcome.
And the presentations will also be available.
Cool. If there aren't any other questions, gang, I'm praying for each and every one of you on the front lines. I'm updating things on LinkedIn. Reach out and join me there if you want. Trying to do 2 or 3 a week, and they're light content, just trying to put tips and strategies out there from a revenue cycle standpoint based off what I'm hearing and what I've seen and what I've been through. And if there's things from this deck that you need to talk about or get with me, feel free to give me a call and or send me an email. But hang in there. I do see daylight. I do think we're approaching in the next few days or weeks the backside of this curve. Social distancing is still going to be necessary to achieve that and get where we need to be. But I do see healthcare being stronger after all this is done. And I'm just hope this information was valuable to you, and you all have a fantastic rest of your Friday and good weekend, and hang in there.
Thank you, Jonathan.
Thank you.
I do just want to reiterate, thank you to all of you for attending today. My apologies for anyone who may have had some difficulty signing on in the beginning. After all the information came out about Zoom hacking, we decided to add a password, and that was sent out to everyone, but I know our emails often, because they are automated, get caught up in your spam and junk filters. So thank you all for your patience. This was also our first time hosting on Zoom. So very appreciative of your patience if you had any trouble getting in this morning. I also wanted to just reiterate, I will be sending out an email with a link to the replay with the presentation as well. That will also be coming from our registration platform. So be sure to double check your spam and your junk mail folders if you don't see that, probably by tomorrow. As Jonathan mentioned, next week we will be hosting another webinar. It will be COVID-19 BDO's Insights into Emergency Relief Funding. That's presented by Chad Kirchel, who is the Director and Healthcare Advisory with BDO and the Colorado Chapter President. Pardon me. You can find registration information on that webinar on the HFMA Colorado website, which is hfma-co.org. And that concludes our webinar for today. Thank you all for joining us. Have a wonderful, healthy day.
Thank you. Thanks, Jessica. Take care, everyone.